Good morning, everybody. Welcome to Neurosurgery Community Grand Rounds. Our topic today is spasticity management and cerebral palsy. It's a topic that I'm really excited about. It's one that really brings joy to me when I see some of these patients in follow-up. So I'm glad that you joined us this morning. So I'm Peter Sun. I'm a pediatric neurosurgeon at Benioff Children's Hospital. I'm mostly based in Oakland. Joining me as panelists are Yumi Mitsuya, or rehab physician, Courtney Sagar, or rehab physician, Lucy Tomlinson, our physical therapist. So we want this also to be interactive. So please ask questions in the chat box, and we'll try to answer them as we go along. This is our group. This work is a collaborative effort from our spasticity clinic that we started back in 2005. This is Dr. Peacock here. I actually didn't train knowing how to do SDR, so he joined our clinic. I learned from him, and I'm really grateful for Dr. Peacock's contribution to start our clinic, and we've been going strong since. And this is our last picture. Bob and I are the ones that are still there. Bob Haney, of course, is our other rehab physician. So we all know what cerebral palsy is. It's a group of disorders that comes from disruption of the fetal or infant brain development, and it results in motor and other disturbances. It's the most common childhood physical disability worldwide, and in the United States, there's close to 1 million people with CP, and the incidence is close to 3.5 out of 1,000 at age 8. So we're also familiar with the paradigm. We have some sort of brain injury that results in loss of inhibition and modulation of the intrinsically hyperactive and dynamic spinal reflexes, and the result is we have hypertonia, or increased muscle tone. So there's various types of hypertonia in cerebral palsy. Spasticity is defined as velocity-dependent resistance to muscle stretch, and it is the most common form of hypertonia in cerebral palsy, as we can see here, although these types are frequently mixed together, and it's important during physical exam to try to tease out what patients have. So there's a variety of ill effects from spasticity and cerebral palsy. It inhibits motor development, causes muscle contractures, reduces function, daily activities, and exercise, interferes with care, positioning, and tolerance of braces, causes people to fall, have chronic pain. Obviously, it increases the burden of care for the caregivers and parents, and it certainly creates social stigmatization. So functional performance in CP is classified by the gross motor function classification system from 1 to 4. Level 1 is defined as basically normal. You can run, may have difficulty on uneven surfaces or with endurance, some balance issues, but very functional. Level 2, cannot run, but can get by walking. Level 3, walks with assistive device. Level 4, can assist in transfer. Level 5, we're severely affected and cannot stand or sit. So the goal of spasticity management is to improve gait. Gait obviously is a coordinated concentric and eccentric muscle contraction, and spasticity management can greatly facilitate this in CP patients. We also want to improve motor activities in daily living, other types of motor activities. We want to decrease orthopedic deformity, improve comfort, minimize pain, decrease burden of care, and also, improving cosmesis is not an insignificant factor. So, of course, spasticity management comes in many forms. And we have medication, PTOT, bracing, casting, Botox, and other injections. Today, as neurosurgery grand rounds or community rounds, we're going to focus on selective dorsal rhizotomy and intrathecal baclofen pump therapy. So just as an intro to the audience before we get into our content, I'm going to ask everybody to just see which neurosurgical treatment improves upper extremity spasticity. Intrathecal pump, SDR, selective dorsal rhizotomy, both A and B, or neither A or B. All right, we'll move on and take a look. Yep, okay. All right, so starting with selective dorsal rhizotomy. Selective dorsal rhizotomy is cutting the dorsal nerve roots in the lumbar region to reduce reflex and tone. Since we have loss of inhibition, we have the hyperexcitable spinal reflex, and selective dorsal rhizotomy is to cut some of these to reduce the reflex and tone. The reflex physiology was actually worked out by Sherrington back in 1898. And in the 1970s, Fasano introduced the concept of selecting abnormal responses from individual nerve roots, hence the selective and selective dorsal rhizotomy. Dr. Peacock popularized this treatment in North America in the 80s and 90s, and Dr. Park refined it to a one-level laminectomy as opposed to a 5-level or 4-level laminectomy. And I find it interesting that exactly 120 years after Sherrington worked out the reflexes, in 2018, the National Health Services in England concluded that SDR improves his gross motor function and quality of life and would be funded. So today we are moving into an era where SDR is a more minimally invasive operation, and we can see benefits for more affected children and its effect on upper extremities. All right, so this is the paradigm. The paradigm is we have patient prone in the operating room. We have electrodes in the various muscles and the anal sphincter. Our setup is that we can also test clonus intraoperatively with a clear dressing. The conus is exposed. They're individually stimulated for the most abnormal responses that we can detect in the electrodes. We have worked out our own classification. The normal nerves are just a square little response block. The abnormal ones can be sustained, or they can cross over to the other side and affect multiple other muscle groups. So those are the ones that we classify as the worst nerves, which are selected for rhizotomy. So the selection criteria, we like to get to children early if we can. There's two types of SDR. The first type is functional, where we're trying to improve function. So age, we want to be young, but greater than 3 to 4, so they can cooperate with our 4 to 8 weeks of inpatient rehab program, which we think is very important. Patients with the most predictable and consistent favorable outcomes are those with CP from prematurity, although other etiologies are considered. We want their hips to be stable. We don't want them to be over-lengthened with orthopedic surgery first. That makes a rhizotomy very difficult to predict in terms of outcome. If they have had that, good response to Botox certainly is a good indicator. I tell families that's a good preview of what rhizotomy can do on a permanent basis. And they need to be able to follow directions and participate with therapy for our program. So also we do SDR for therapeutic or palliative effect, and these are patients that are more affected, GMFCS 4 and 5 for improved ease of care and comfort. For these patients, the upper extremity can improve as well, and we'll show that. We want the spasticity to be predominant and little to no dystonia, because that can become amassed. Moving on to intrathecal baclofen. Baclofen is an inhibitory GABA receptor agonist, reduces spinal reflex. The drug can be delivered by pump through an intrathecal catheter directly into the intrathecal space, so we're not taking it orally to affect overall systemic issues. It is reversible, it is adjustable. The location of the catheter is variable and can be targeted to the upper extremities, and it does have effect on dystonia, but it has costs associated with it. Of course, it needs refills and replacements, and there's a variety of hardware complications that can result. It's reserved for more severely affected patients for us and those with dystonia. And for spastic quadriplegia patients, it really overlaps with our therapeutic SDR, and we're leaning more towards SDR in these patients due to some of these factors now. All right, so spasticity management, of course, is just part of our multidisciplinary hypertonicity management, which includes PT, exercise and diet, bone and joint alignment, orthotics, and those patients with movement disorders in our clinic, some of them may be candidates for deep brain stimulation. So when we refer a patient to our hypertonicity clinic, we're really talking about a multidisciplinary evaluation by our physiatrist, orthopedic surgeons. We also have a neuromuscular neurologist, neurosurgeon myself, movement disorder neurologist, PT, rehab, nurse clinician, social worker, and dietitian. So collectively, we go through these assessment questions. I think in particular, we want to know their family situation to see if they can stay with us for prolonged inpatient stay. That's important for the SDR program. And then we have to set goals and expectations in terms of what we are doing with spasticity reduction. And these include to simply be more comfortable, to have better ease of positioning and daily cares, perhaps be able to transfer or use a walker, walk without a walker, even walk better or run, and perhaps improve cosmesis. So I think these are all reasonable goals, all goals that we can achieve, but we must be able to delineate what is possible. And I think that's best done by going through some of our patients. So here's patient number one.
All right, so patient number one, he's a 6-year-old with history of premature birth at 35 weeks with spastic diplegia, was functioning at a GMFCS2 level. He walked independently at age 2, but in what we call a true equinus gait with the ankle and plantar flexion throughout the stance phase and the hips and knees extended. He also has some adduction and internal rotation at the hips. He had fairly good balance, but due to the spasticity, he required handrails to navigate stairs, and he was unable to run without tripping frequently. And here again, you see that his static balance is pretty good, but due to being up on his toes, squatting is difficult without handhold assist. However, he's able to come back up to standing, showing that he has fair hip strength, which is a good prognostic factor after SDR. He had an instrumented gain analysis at an outside center and was recommended that he not proceed with an SDR. His spasticity was worse at his ankle plantar flexors, and he did have plantar flexion contractures that he had developed over time. The discussion within our team then was whether he would benefit from a heel cord lengthening procedure versus a rhizotomy. With shared decision-making with the family, though, he ultimately underwent an SDR followed by an inpatient intensive rehab course. And this is him on the left, 4 months post-op at an outpatient follow-up visit. He's requiring a walker to take steps with heavy reliance on his upper body to maintain an upright position and with a lot of effort to do hip flexion to advance his steps, but he's starting to get some good heel contact on the floor. We do see that a lot of times after removal of spasticity post-SDR, with aggressive stretching and things like serial casting and splinting during the acute rehab course, we can get significant improvement in range of motion at the knees and ankles. And on the right, 2 years post-op, he essentially has a normal physiologic gait. And on the next slide, here he is as a young adult living his best surfer life with his feet beautifully flat on the surfboard, and your balance really can't get any better than that. And when he went to college, no one knew that he had cerebral palsy, and when they found out towards the end of his senior year, they offered him a full scholarship for a master's program from which he graduated last year. So with the SDR, his GMFCS level improved from 2 to 1. He now has a normal gait that has been sustained over time. And if we had gone with the heel cord lengthening instead, we may have wrist over lengthening at the Achilles, leading to development of a crouch gait. It wouldn't have addressed the hamstring or adductor tone. And with spasticity still an underlying problem, the plantar flexion contracture may have recurred over time. He did have an L5 pars defect that required repair as a teenager that Dr. Sun will touch on in a later slide.
Yes, so we started off doing the multi-level laminoplasty. I just wonder if that had any impact on the development of the pars defect, but I think this patient nicely illustrates what we see in the literature, and that our SDR results are sustained over time. And then independent walkers and diplegia patients will have the smallest amount of subsequent orthopedic surgery post-SDR. From a multi-level laminoplasty, we've really turned this into a minimally invasive surgery where we do a single level laminoplasty. Laminoplasty means that we don't even take off the bone. We lift it up as like we hinge a door and we put it down. And the exact level of the laminoplasty is determined by a quick scan MRI, which just takes 5 minutes, and these patients don't even need sedation for us to know exactly where the conus is. And once we visualize where the conus is, we design our cut to expose the conus. And you can see the incision now is only 3 centimeters, so after we expose the conus, this is the dura. We open the dura. We simulate individual nerves like we were talking about to find the worst nerves. And 50 to 70% are cut per the neurophysiological findings. And as it turns out, sensations very overlap, and we don't have any permanent sensory impact. And there's some evidence even now, besides the clinical improvement, you see that on muscle biopsy or muscle measurements, it facilitates muscle regrowth. So moving on to our next patient.
Yep. Our next patient is 6 years old. He was a GMFCS3 community ambulator with a reverse walker and could take steps also with handheld assist, but in equinus, a crouch at the hips and adduction and internal rotation left, worse than right, with his knees, especially on the left, not getting much extension during swing phase due to hamstring spasticity. And on stance phase, he shows hyperextension at the knee from a combination of the plantar flexor spasticity and quadriceps weakness. His balance is poor, as you can see, and you'll also note that in taking steps, his arms are in a flex position due to dynamic tone kicking in at the upper extremities as well.
Yeah, he's pretty weak, isn't he? And what are our goals going in?
So it was for him, goal setting was a challenge, kind of setting realistic expectations. We weren't sure with the spasticity removed how much balance he actually had. But after his SDR, it became apparent he actually had fair balance when his spasticity was out of the equation. And this is him 1 year post-op, and he's now walking independently. And he still has impaired ankle dorsiflexion and has a mostly flat foot contact, and with some quad weakness with that hyperextension that you still see on stance. However, with AFOs on, his knee hyperextension resolves, and he was even able to run, which he couldn't do before. And you can also see that his arms are now more nicely extended at his sides instead of in a flex position. To get to this point, post-surgical inpatient rehab was really crucial for the initial neuromuscular retraining, to have the therapist really guide his movements so he could relearn the more physiological muscle activation pattern for moving and walking, and not revert back to his previous walking pattern.
Yeah, I just think this kind of result is really made possible by our extensive inpatient rehab part of the rhizotomy program. So we know that there are prospective studies for SDR that shows that it gives better motor measure scores than PT alone. But I think we'll have Lucy talk a bit about our inpatient rehab program, or the PT component, which is integral to our SDR program and enhances the outcome.
Hi, yes. So in the after a rhizotomy, it's different than other injuries that you see in rehab, whereas from a brain injury or something, you're trying to revert back to where you once were. But after a rhizotomy, it's different than trying to revert back to where you were or developing in general, because what you're trying to do is have a new motor pattern. And that's why it's very, very important to go back to a basic strengthening level, because these kids were using tone instead of true strength. And it was in a non-ideal position, usually a crouch gait or something, where some of the muscles, like your quads, are in a lengthened position when they contract, and other muscles like hamstrings and gastrocs are in a more contracted position when they're trying to contract, or shortened position when they're trying to contract. So we need to get those muscles to contract in the more lengthened or shortened positions. And that means that it is kind of in the basics in the beginning, with a lot of more strengthening prone exercises, things of that nature, and not walking right in the beginning. You can't just get up and walk. And I think that's something that needs to be expected. I think you saw in the patient, in the first patient we saw, the 4-month post-op, before you're like, oh, they were walking without a walker up on their toes, and 4 months post-op, they're walking with a walker. But it's a very much of a long game, and you can't just jump right back into it. And you have to give them the supports that they need in the beginning, so that we can actually have these very long-term results. So it is a long-term game with therapy going on for a lengthened period of time, but most importantly, getting kind of a better contraction in the new positions they are before getting them up on their feet and just walking.
Yeah. I think the fact that it's a long game is so important to emphasize. For example, this patient, right, at age 4, you can see how weak we are. Spastic thigh. I think this is another patient who you would not imagine this result without an extensive inpatient rehab that we see 5-year post-op. I would say this patient we saw initially at 4 and waited till 6. Today, I might push for this patient to be done a little earlier, because we still have some muscle contracture issues. But he's, going from here to where he's walking independently, I would have to say I couldn't really say that we knew that was going to happen. So I think PT, or inpatient rehab program, is critical. All right. Next patient.
So our next patient came to us at 8 years of age. He was a GMFCS2 and a community ambulator with AFOs, but we can see that he has very poor postural control and balance, some scissoring up on his toes, but really almost kind of an ataxic gait with variable foot placement with each step, and arms that come up to high guard to maintain his balance. He was very conscious of his gait and how it made him stand out so much from his peers. But in our pre-op discussions, again, similar to our previous patient, in setting realistic expectations and goals, we weren't entirely sure what his ultimate potential would be, since he had such poor balance as well as apparent weakness that would be further unmasked following removal of his spasticity. So you can see also that he had a lot of clonus there. And then here, this is him 8 years later. And what a difference, right? His feet now come nicely down to the floor. His knees still stay in some flexion throughout the gait cycle, and he still has some truncal sway, but he was happy with the results of his SDR, stating he could now walk without his AFOs, because, side note, as we see in most of our kids, they stop wearing their AFOs once they get to preteen age, since they don't want to wear anything that makes them stand out from their peers. But he was able to walk long distances, not fall, and he said at that time he now feels normal. And following the appointment at which the previous video was taken, he underwent iliopsoas and hamstring lengthening at both legs, leading to an even smoother gait. And at 22 years old now, maintained his hobby of playing basketball with his buddies. And we can still see a bit of that truncal sway there, but he has a gait pattern that a non-medical person would likely not notice as being different, and may simply characterize as walking with some swagger.
Yeah, what a difference, right? Comparing him to 8 years ago, 14 years ago. Yeah, so we know that adult CP patients have a higher rate of anxiety and depression. And I think this patient is a nice illustration of, you could get to a point that you essentially look normal. And SCR patients being followed for long term actually have similar anxiety and depression scores compared to typical developing adults. And I think in large part due to the effects that you were able to see there. All right, moving on to our next patient.
Our next patient is a 7-year-old who was 7 years old when he presented to our multidisciplinary spasticity clinic with a past medical history of prematurity, born at 29 weeks, and periventricular leukomalacia seen on MRI, suggesting diplegic cerebral palsy. He didn't take his first independent steps until around age 4. But his parents stated their functional goal was with surgery was to make him look normal. And he's already walking at a GMFCS1 level, so the question is whether he was too good for an SDR. You can see him on the left walking with decreased dorsiflexion. He makes initial contact to the forefoot, but he's still able to get his foot flat in stance. He has mild increased adduction from normal with a shorter stride. And his gait would not be described as typical, but it is kind of more normal than what we'd see for others in this presentation. But then we see him 1 year post-SDR, and you see him taking longer steps with less scissoring, faster cadence. He still has some decreased dorsiflexion with whole foot contact while walking, as well as a little bit of a steppage gait to compensate. But overall, the gait does appear more normal, so parents' goal was achieved. He does go from being a GMFCS1 to a better one. He'll walk further distances, and he'll hopefully have less breakdown at the midfoot in the future with better placement of the foot and ankle in stance.
Yeah, terrific. Right. On to our next patient. This is a more difficult patient.
Yeah, definitely. He's 8 years old, born at term with increased periventricular signal on MRI, history of Sjogren-Larsen syndrome, and his primary method of mobility at home was crawling. His initial video shows significant scissoring and severe flexion at the hips and the knees, and he's high up on those toes. He requires handhold assist for the limited mobility that he has, putting him at like a GMFCS 3 to 4 level. It's not really like a true functional walking, as he would not be able to sustain this for a notable period of time. But if left untreated, he would eventually lose the limited walking that he has and require a wheelchair for all mobility, making him a GMFCS 4.
And I think, Courtney, if for any therapists that are watching this, you would look at this and say, I can't really do much with this in the community right now as far as physical therapy to get walking to be better. When you're in this state, there's not much to go off of from here without some further intervention from the medical team.
Definitely. So here on the next slide, we see him post-SDR, and he's still requiring handhold assist or a walker to ambulate, but you can see how noticeably more comfortable he is with more dynamic range of motion. His hip and knee contractures are obviously still persisting, but removing that spasticity will allow for improved orthopedic outcomes when he eventually gets those released. It will make his future surgery and recovery easier with less chance of contracture recurrence. And you'll also notice that he has his feet flat in this video where he didn't in the post-op video. So this kind of demonstrates the importance of having the SDR before the orthopedic intervention, because he would have been at risk for over-lengthening the tendons on that thing. And so this is kind of, we're seeing that on this slide as well, that our ideal timing is age 4 to 6 and then prior to orthopedic surgery. And then they may need some intervention post-operatively with orthopedic surgery to release contractures.
Yeah, we really want to try to get to them before they get to stage 3 and 4 as optimal candidates for SDR. And this is what Dr. Sagar was saying. The natural history of certainly 3, 4, and 5s are that it can get worse over time. And we can see from our last patient, there was no way he would have maintained even being able to do what he was doing. But patients' status post-SDR do improve function over time. All right, our next little patient.
She presented around 8 years old with spastic diplegia and bilateral equinus contractures that were definitely not braceable. The stated goal of her and her parents was to tolerate brace use and to ambulate better using a walker. You can see here that she is a 3 at presentation. She's requiring a walker to move. Prior to her SDR, she's up on her toes bilaterally, secondary to tone and those ankle contractures. Her hips are not consistently adducted, but she's still crossing midline with each step and circumducting and hiking her hips to clear her toes. And then you see her at the MTU post-SDR, ambulating for shorter distances with contact guard assist on the left. She won't be walking long distances like that, but it really would improve helping with transfers and shorter distances at home. And you'll notice that her ankles are in a better position because she's tolerating bracing now. In the second video, you see her being much more confident with her reverse walker. She's still up on her toes more, a little bit more on the left than the right, and her overall gait pattern is much improved. She'd be able to sustain ambulation all day during school with the walker, which is a big improvement from where she was.
Yeah, definitely. All right. Our next patient is a different sort of category. We're moving on to our therapeutic patients.
Yeah, he is 7 years old at the time of his SDR. He was a very premature kid at 24 weeks, a spastic quadriplegic CP, GMFCS4. He was able to stand and take a few steps around age 1.5, but then had some regression, was no longer able to walk after age 2.5. We tried some botulinum toxin injections, but if any effects that were seen were very short-lived. You can see here in the video that he has severe adductor tone, limiting his ability to bear weight or through his feet at all, even with considerable support by our therapist, the trunk. And his goal was to use a gait trainer. The video on the left is still pre-SDR, and he required abductor straps, which are essentially exercise bands on either side of the walker to keep his legs apart. Even with that intervention, you can see that he's not really able to advance his steps to move his feet forward. Rather, he's kind of pushing himself forward with both feet to propel the walker forward just a short distance. And post-SDR, you'll see that he is using a gait trainer without the straps. He's still kind of doing that push-off method and almost hopping forward to propel the walker, which isn't true walking, but it's certainly more enjoyable than what he was doing before. He's able to bear the weight through his feet, which is better for bone health. And I think it's also important to point out that it's really psychologically rewarding for both the parents and family to see any kind of form of walking with their child, even if it's not necessarily permanent. And the other thing I think to point out with him is that you can't see it in this video, but you can kind of imagine how much more comfortable it is throughout the day for him to just exist. Doing cares for him, including bathing and dressing and diaper changes now that his legs can open up is substantially easier for the family. And he's also able to prevent future orthopedic complications due to contractures with the decreased tone in his lower extremities.
Yeah.
Moving
Moving on to an older patient.
Yeah, this is a 13-year-old. He's a little bit older than the rest of our kids at the time of presentation. He has a history of prematurity, shunted hydrocephalus, and a mitochondrial disorder leading to spastic quadriplegic CP. We classify him GMFCS 3 to 4. You'll notice he has a very high steppage gait in the first video. Ankle contractures are more impaired in the second, as he can't really get his feet flat. But you'll see that he's really bearing a lot of his weight through the platform walker to stay upright, and just kind of moving his feet forward distally. And the question here is whether he's too old to benefit from an SDR, as it may be harder for him to build his strength back up and relearn to walk given his size. There's also the question of whether he has adapted to using his spasticity to maintain that upright position for transfers and limited walking, which we'd hate to take away.
Yeah, I mean, also a bedside exam shows that he has clonus and hyperreflexia. So we felt that even though he may be using some of his spasticity, right here is highly dysfunctional. He's scissoring. He's kind of his crouch. He's got that midfoot break, right? So he's got a lot of tone there. So we went ahead with him.
Yeah. So here you're going to see him post SDR. He didn't have to bring his walker to clinic that day, so he's walking with handhold assist. He's still in a bit of a crouch position, but he's using his support person more for balance than to really support his weight, which he was before with that platform walker. And this change of function would decrease his caregiver burden substantially as he gets older, as he's more easily able to transfer and walk short distances within the home. It'll maintain his ability to be upright for longer.
Yeah. Lucy, did you know him?
Yes, yeah, he was actually my rehab kid. But yeah, when I was on rehab, I worked with him for quite some time.
Yeah, good job.
Thanks.
All right, we have a few more patients left.
Okay, so this is our 9-year-old with spastic quadriplegia secondary to anoxic brain injury following a cardiac arrest that happened post-liver transplant. He's dependent for all mobility, ADLs, and communication, though he's working on using an IES communication device. He has significant spasticity at all of his extremities, despite being on multiple spasticity medications and having had multiple Botox injections. And the lower extremity spasticity in particular was really making his daily cares extremely hard. So in the left video, you see the quadriceps spasticity making bending the knee difficult. And when he would get upset or sick with a cold or something, his adductor spasticity would also kick in, making diaper changes and lower body dressing really difficult for mom. He also has significant equinovarus contractures at the ankles. And on the right, you can see Lucy here arranging his legs much easier post-rhizotomy, and even his ankles now get passively almost close to neutral. Much easier to tolerate bracing, and with bracing, hopefully can prolong or avoid future orthopedic surgeries for his ankles. And after his, sorry, Peter.
Yeah, but like we'd be like, well, what is the point of this, right? Well, the point is.
Yeah, so after his rhizotomy, his mom said something that really wowed us, that she now had so much more time and extra energy that she signed up to run a half marathon. And parents of some other patients have also given us feedback of maybe unexpected, but kind of cherry on the top type effects they were experiencing after their child's rhizotomy. One parent told me they were no longer having to do digital stimulation to induce their child's bowel movement. Another parent was crying when I visited them at bedside on post-op day 2, saying they had never seen their child smile so much in their life. And she was already like 8 years old. Many have told us that their child is now sleeping through the night, allowing the whole family to get better sleep. And we get to know most of these patients really well leading up to the surgery, since a lot of the time we're seeing them repeatedly in our rehab clinic for medication adjustments and injections. And like Peter mentioned earlier, it gives us so much satisfaction and joy to not only see these patients being more comfortable and happy, but also to see their families really thriving.
Yeah, and we see this in the literature as well. This is a publication this year that shows that the impact of selective dorsal rhizotomy to these children really improves the caregivers' burden, the surgical group, with statistically significant change there. We also have literature that's coming out to suggest, this is also published this year, that selective dorsal rhizotomy improves the life of children with stage 4 and 5 level 4 and 5 cerebral palsy with pain, positioning, dressing. These are all significantly improved. Yeah, it's one thing looking at these charts, but what Yumi just talked about just really brings it home to see the impact of positive impact on quality of life and reduction on caregivers' burden for these children. Our own questionnaire that Melissa or our nurse clinician sent out to families also backs this up, and that patients are happier after rhizotomy as much as baclofen pump, or even more so that there's a positive impact on the quality of life. This is a patient who had a baclofen pump. I think it's illustrative of something we want to point out, and that this patient had a baclofen pump, but was kind of tired of the changes in the pump, the frequency by which she had to come in for refills. This is her with the pump, so she still has a lot of tone. The catheter level is at T8, so we had hoped that there would be some positive effect on her arm, but she really wasn't able to use her arm that well. I think if we had put the catheter level at a higher position, maybe T1 or C7, that would have done more for the arm. Obviously, she has a hemiplegia on the left, but in terms of the right arm, but then if we had put it that high, we may have lost some tone reduction in the legs. So she was converted to a SDR. And I want you to take a look at her right hand. She has much more control of her right arm, and also reciprocal abilities in her lower extremities. And in fact, she's able to ride a tricycle after the rhizotomy, and able to steer it with her right arm. So more and more we're seeing in the literature that upper extremity spasticity and function does improve after lumbar selective dorsal rhizotomy. We have hypotheses to explain why that might be the case, but we don't know for sure. But clinically, we definitely are seeing that, as illustrated by the last patient. And this is, again, our questionnaire for our patients, and we can see that many have responded that the surgery has also improved upper extremity function, as well as the other questions in this patient questionnaire measure.
And lastly, we have patient 12. His initial surgical evaluations was at age 4. He had a pump placement around age 7. He has a history of spastic quadriplegic, CP secondary to HIE. His tone was mixed with both spasticity and dystonia, which is why a pump was favored. And you can see him on the left even struggling to stand, given the tone and posturing, limiting his intentional movements. Post-pump placement, you can see him taking some very supported steps with less spasticity and dystonia, but his gait is truly not functional. The video demonstrates improved range of motion and some decreased posturing with his intentional movement.
Yeah, less dystonic leg movements there, doesn't he? However,
we chose this case to demonstrate some of the downfalls of using an ITB pump. He underwent a spinal fusion at age 13 and subsequently developed a kink in the catheter that caused significant withdrawal symptoms, and he required emergent ITB pump catheter revision. Additionally, he's on a very high dose of baclofen to maintain the improvements that he has, so he has to come in to the hospital for refills every 5 to 6 weeks. Another downside is that whenever he presents to the ED with any kind of medical concern, the pump malfunction is always suspected to be the cause. And so it has to be ruled out before really any other workup is started. So this delays his medical care. He's having unnecessary imaging and pump interrogation consistently upon arrival. He's presented with increased tone secondary to viral illnesses, UTIs, and most recently for recurrent kidney stones. They've sent him home from the ED twice with UTIs, and only on the third presentation did they check for stones despite a known history. He lives a ways out from Oakland, but he has to consistently come here for care so that providers would be comfortable with managing him at all because he has the pump in place. All this is to say that when we can, SDRs are pretty preferable to pump placement at this point when they're appropriate, with fewer longer-term complications and risks.
All right. We have a question here. Can an SCR still be done on patients that have had hip surgery or spinal fusions? The answer is yes. With spinal fusions, with SDRs, if it extends to the level that we're going to need to operate on, we certainly have to work around diffusion mass. Instead of the technique I was describing where we lift up one spinal level and is able to put it back down, kind of restoring the physiology and the biomechanics of the spine, or we would have to draw a trough in the spinal fusion level and work within the trough, which is entirely doable, and we've of course done that. And in fact, in patients who we want to put in a pump, similarly, if they've had a spinal fusion, we would drill a small hole in the spinal fusion and actually use a mallet to tap through the inner cortex of the spinal fusion to thread the intrathecal catheter. In terms of hip surgery, one of the earlier slides we pointed out is that if their hips are just coming out, we definitely want that to be fixed first before going on to SDR, because of the reduction in tone and how much rehab we have to do afterwards. We want to have a functional and not painful hip. Moving on. This patient is a 14-year-old patient who has a history of hypoxic brain injury. On examination, there's sustained clonus and hyperreflexia. And we saw them at clinic. The parents want him to take steps and transfer better. So we see he is being held up by mom, supporting pretty much his entire weight. He is able to keep his legs straight and kind of pivot and then sit down. Lucy, what do you see here?
I see that he's using all of his tone to stand. And if he were to try to take that tone away, I don't think his transfer would be better. So SDR would not be a solution for this patient in order to continue to transfer, which is one thing that PT helps with in clinic, is looking at the functional use of what they're doing, how we collaborate as an interdisciplinary team in our spasticity clinic.
What? We're not going to do an SDR after this whole talk?
Yeah, you don't just because we like SDRs, Dr. Sun, doesn't mean we do them on everyone.
All right. So to the audience, which neurosurgical treatment is appropriate to preserve stand and pivot transfer for this patient? I'm interested to see this. Yumi, would you consider a pump for this patient?
I think a pump would be a reasonable option since it's titratable and there's less risk of weakness.
Yeah. I mean, definitely not an SDR, right? If we're going to preserve this. I know our answer isn't out yet, but I would agree. I would say SDR would have significant risk of taking away that spasticity. So that one function that the family is kind of counting on these days, which is the stand pivot transfer, could be lost. So this is a quote from the most famous SDR surgeon, Dr. Park in St. Louis, who retired this year, who has done over 4,000 SDRs. And he says that considering the rationale for SDR, it's essential to note that there is currently no proven benefit of spasticity in CP. By contrast, the adverse effects of CP spasticity are well known. Ideally, spasticity must be removed to prevent lifelong harmful effects. I guess this is generally true for a young patient, but as we saw from the last patient, certainly not all spasticity needs or should be treated. For that patient, we wanted to preserve stand pivot transfer. You can argue how important that is for him over the rest of his lifetime versus continual orthopedic contractures and deformities. But I think if we did it, it certainly would have disappointed the family in terms of what their expectation was. So I think our point is that each patient must be evaluated individually, and families' expectations and their concerns and wants are, of course, obviously important.
And I think to speak on that further, that one of the things that you do really well, Dr. Sun, is that you, when you look at the patients individually, you try to individualize like the degree to which you're affecting each patient, and kind of thinking into their degree of function and what you're able to preserve and how you're able to improve them.
Yeah. All right. So I see another question here. We'll have time for questions to answer. So we have a very important question about gait lab that I see in the chat group. But just looking at our complications over the last several years, between pumps and SDRs. There have been some medical complications, not that severe, thankfully. Certainly with our pumps, we do have a much higher rate of reoperations within 30 days in terms of, catheter blocking, leakage, so on. And sometimes the SDR patients need a wound revision just because, they sweat a lot or things like that, but we've not had any CSF leaks and we've not had any bladder dysfunction. One patient had a very much increase in dystonia that was unmasked, and we did have one patient with a femoral neuropathy from positioning prone. That was a big lesson for me because he's one of the heaviest patients we had, and our horizontal bolsters, I think, did cause him to have a femoral neuropathy. And since then, we've changed our positioning protocol for heavier patients to Wilson frames. So I think we all know this by now. The answer is both. And the answer here is also both. Although we didn't present the data on intrathecal pumps, there are papers out there and literature out there indicating that it also improves quality of life. But it just has a lot of potential complications and overall escalates the medical care significantly in these patients. All right, I think we should all take this question on. We have a question here. In the clinical, we have a question: in clinical setting without gait labs, what practices have you found effectively standardized the use of patient ambulation videos for post-op gait evaluation? Any thoughts on incorporating AI into these evaluation? Well, to answer that question, we really want a gait lab. And we are working with administration as my 20-year project, working with the hospital to establish a gait lab, and it's ongoing. I think gait lab is very important, both as a SDR evaluation tool and also post-op assessment tool. But we've just been able to. There's some selected patients on one of my previous slides that we do send to a gait lab to get data where kind of feel like that's really important. The other ones, I think it's just clinical experience have guided us to choose the patients. If they have clonus, hyperreflexia, they responded to Botox. Those are important criteria too for us to know that they do well. And I think certainly AI, the second half of this question is any thoughts on incorporating AI into these evaluations? No doubt, obviously you have to have data for AI, and no doubt the gait lab data, I think, will be very, very beneficial with AI to sort out, because as you know, looking at all the kinematics and all the kinetics and all the data from a modern gait lab, that's a lot to analyze, and I think AI will help a lot with that. What do you guys think?
Yeah, we've really, I think at the center, we've had a lot of experience collectively with my mentors that we don't really have a standardized system for evaluating the clinical evaluation of gait, but have relied on that collective experience to really describe pre and post-op. On a similar note, we get a lot of questions about, what if there is any presence of dystonia, is the patient really not a candidate for an SDR? And we certainly, we take that question really seriously because, as Peter mentioned, we've had cases, one case where dystonia was unmasked and became very difficult to control. But we have had patients who have some degree of, mild dystonia, maybe in their upper extremity, who have undergone SDR and still have benefited functionally from it. And so that's another question that we're trying to answer. With dystonia, there's also not a lot of standardized assessments other than, the HAP tool. There are some grading tools that we use, but we also currently rely on, the collective experience and exams together with the neuromuscular neurologist and the movement disorder neurologist. But these are all questions that are that need to be looked into more in the future.
Yeah, so in conclusion, spasticity is, of course, just one component of cerebral palsy, but it is amenable to treatment, unlike some of the other more difficult aspects of CP. And spasticity treatment, including SDR, can improve function and quality of life. And this has to be done in a multidisciplinary setting. So thank you for your attention. We have a few minutes left for any questions. If there are any, well, great. I think there's a lot of information. I think it gives us kind of a glimpse as to what is possible. I think one thing that's kind of unique about our center is I've been around a long time, so we have long follow-ups to see some of these videos of our patients that they sent back in. Really have meant a lot to me, and I'm happy to have shared them with you. Oh, to her patients, I think rehab is the gateway to the spasticity clinic. So they're the ones to contact, and also, of course, me as well. I think this video will also be on YouTube and under the UCSF media if you want to refer patients to see it or contact us. Thanks so much, guys.
So he has spastic diplegia cerebral palsy, which means that it affects from his waist down more than any other part of his body. And before the rhizotomy, he stood only on his tiptoes. He wore braces to try to bring that heel down, but his leg was constantly pulling his heel up into a tiptoe position, so that just doesn't allow for any stability. You just can't maneuver through the world without tipping over easily. The first person that ever talked to me about rhizotomy was Dr. Sun, and that was through a process. We go to a spasticity clinic once a year, and they follow Creighton, and they're paying attention to his cerebral palsy and how it affects his functional life. And so when he was about 4 years old, Dr. Sun said that he was a good candidate for it. It wasn't time yet. He wanted us to do the research and find out if that was a good decision for us. Before he had the surgery, his legs were tight, and he spent most of his time in his wheelchair. He was out of his wheelchair at home and in his classroom, and he had canes that he could walk with, but it wasn't safe for him to be in groups of people or out in the community outside at all because he fell.
Although we're looking at a picture of him now, we have to imagine a picture of him, 30 years from now. And what can we do now to make that better? Creighton went through the evaluation. We felt he was a good candidate for rhizotomy. He got the rhizotomy, and now he's walking better. He's able to walk independently, but more importantly, we know that with his legs flowing in a smoother motion, maybe while he still may need some aid, such as crutches, that over a lifetime, he'll be able to continue to be able to walk in the community without having to resort in a wheelchair, which is what he would have had to do to be able to get around.
How do you feel about the decision we made to have the dorsal rhizotomy?
Good. I could do more skill like that,
Yeah.
stuff.
Like what kind of skills did you get from it?
I could take a shower independently.
Yeah.
Then first there was a little step stool I sat on. Then I moved up to this shower chair, and I was totally, almost about probably 99% independent in the shower, except for my back, and my bottom was kind of hard to get.
I would say rally your support You need people to back you up and go for it. It's hard to do, but 200 times worth it. Just changed the outlook of my son's life. And if your child can have that kind of a change in expectations, it's hard to do. But especially if you're looking at Children's Hospital in Oakland or Dr. Sun, you're in the best hands. They'll lead you through it, and I think we just got tremendously excellent care from beginning to end.
Because of the surgery and because of the rehab, it gave him a new sense of awareness that he didn't have before. And we encourage him to try new things all the time, but a lot of it is himself. He wants to do new things, so we just let him have at it. So I think it was great.
Creighton could have an independent life, that he could eventually walk into an interview and shake the hiring manager's hand, that he would stand at the altar when he got married, were things that we hadn't thought about a lot, but hadn't really expected for him.